Tonight, you will fall asleep on one side or the other, left or right. A decision you make unconsciously, the way you have made it every night for decades. The side you choose determines the direction gravity acts on the acid in your stomach, the blood returning to your heart, the lymph draining from your tissues, and the cerebrospinal fluid clearing waste from your brain for the next 8 hours. Gravity does not stop while you sleep. It acts on every fluid in your body in whatever direction you remain oriented, continuously until morning. The direction matters, and the physics of why begins with a fact about your body that almost nobody knows. Your body is not symmetrical on the inside. Your heart sits to the left of center. Your stomach curves to the left, with its largest curvature forming a natural reservoir on the left side. Your aorta descends along the left side of your spine. Your inferior vena cava, the large vein returning blood from the lower body to the heart, runs along the right. Your thoracic duct, the largest vessel in your lymphatic system, drains into the left subclavian vein. None of these arrangements are accidental. They are the product of embryological development that positions every major organ and vessel asymmetrically. And that asymmetry means your body has a preferred gravitational orientation during the hours when you are horizontal and unconscious. Most people have never thought about this once in their lives. When you choose a sleep position, you choose based on comfort. Which shoulder feels best against the mattress? Which hip bears the weight most easily? The direction you habitually roll toward. Your internal anatomy is invisible to you, but it is not invisible to gravity. Gravity acts on the acid in your stomach, the blood in your veins, the lymph in your ducts, and the cerebrospinal fluid in your brain, according to the direction those structures are oriented. And the direction changes completely when you roll from one side to the other. Start with the organ you will feel first if the orientation is wrong, because nighttime acid reflux is a gravitational problem, and the physics is specific. Your stomach is not a symmetrical sac. It is a J-shaped organ with the esophageal entry at the top and the pyloric opening at the lower right. The greater curvature, the large outer curve of the J, extends to the left. The fundus, the dome-shaped upper portion, sits above and to the left of the esophageal junction and acts as a gas reservoir, collecting the air you swallowed during meals. When you lie on your left side, the greater curvature hangs downward by gravity. Gastric contents, acid, partially digested food, digestive enzymes, pool in the dependent, greater curvature below the level of the esophageal junction. The fundus sits above the gastric pool, holding gas above liquid, the same way a bottle, held with its neck upright, keeps air at the top. The pyloric outlet is positioned above the gastric compartment, and gastric emptying occurs with gravity-assisted flow. When you roll to your right side, the anatomy reverses. The greater curvature faces upward. Gastric contents pull toward the gastroesophageal junction, the exact point where the esophagus meets the stomach. The fundus, now positioned below the esophageal entry, pushes gas and acid toward the lower esophageal sphincter. The sphincter must resist both the hydrostatic pressure of the gastric contents pressing against it and the gas pressure from the compressed fundus below. Think about what this means for the person who ate dinner 2 hours before bed. The stomach still contains acid and partially digested food. If they lie on their right side, gravity pulls that mixture directly against the junction the sphincter is trying to keep closed. If they lie on their left side, gravity pulls it away. The stomach is identical. The acid is identical. The sphincter is identical. Different gravitational vector, different result. Researchers publishing in the American Journal of Gastroenterology measured this directly using ambulatory pH monitoring. Sleeping on the right side was associated with significantly more gastroesophageal reflux episodes than sleeping on the left side. Acid exposure time in the distal esophagus was approximately 50% greater during right side sleep compared to left side sleep. The difference was entirely gravitational. No medication was changed. No diet was changed. No surgery was performed. The only variable was which side of the body faced the mattress. And here is what the sphincter is dealing with during those hours. The lower esophageal sphincter is not a simple muscular ring. It is a high-pressure zone, approximately 3 to 4 centimeters in length, maintained by tonic contraction of smooth muscle in the distal esophagus, reinforced by the crural diaphragm, the muscular loop of the diaphragm through which the esophagus passes. The resting pressure of the sphincter is approximately 15 to 30 millimeters of mercury above intragastric pressure. That pressure difference is what prevents the backward flow of acid into the esophagus. The sphincter was designed to resist pressure coming from below, the stomach pushing upward against gravity in an upright person. That is the geometry for which it evolved. Food and acid pushing up, sphincter holding down, gravity assisting the seal. Every time you stand, gravity is helping the sphincter do its job, pulling gastric contents down and away from the junction while the sphincter holds the line from above. In right lateral and supine positions, that geometry changes. Gastric contents position themselves at the level of the sphincter or above it. The pressure difference across the junction is reduced or reversed. Transient sphincter relaxations that occur normally during sleep as part of the digestive cycle are more likely to result in reflux because the contents are already pressing against the junction when the sphincter briefly opens. In left lateral position, gastric contents sit below the sphincter. The pressure difference is maintained. Transient relaxations occur at a dry junction instead of a flooded one. The sphincter opens briefly, as it does throughout the night, and closes again. But there is no acid waiting at the crossing to escape through the opening. The anatomy moved the acid away from the door before the door opens. The difference between waking at 2 in the morning with a burning chest and sleeping through the night without interruption can be, for the person whose sphincter is marginally competent, whose acid production is normal, whose medication is controlling the chemistry, but not the physics, the difference between right lateral and left lateral position. The acid has not changed. The sphincter has not changed. The gravitational vector changed, and the vector determined whether the acid reached the esophagus or remained in the stomach where it belongs. If you experience nighttime reflux, the burning that wakes you at 2 in the morning, the sour taste on waking, the chronic cough that no medication fully resolves, the problem is not only the acid. The problem is the physics. Gravity is pulling gastric contents toward a sphincter that was designed to resist downward pressure, not lateral or upward pressure. Sleeping on the left side restores the pressure geometry the sphincter was built to operate under. The medication you take for reflux reduces the concentration of the acid. It does not change where the acid goes. A proton pump inhibitor makes the gastric contents less acidic, but the contents still pull against the esophageal junction when you lie on your right side. Less acidic fluid pressing against the sphincter for 8 hours still produces irritation, still triggers coughing, still causes the microaspiration that produces the morning hoarseness many reflux patients report. Left side sleeping addresses the vector, not the chemistry. The medication treats the chemistry, not the vector. The two are complementary, but the position change alone, in the data from the Corey study, reduced acid exposure by 50% without any change in medication. Consider the person taking reflux medication and still waking with symptoms, the persistent cough, the residual burning. The medication may be working exactly as designed, while the physics works against it. The chemistry is controlled, the gravity is not. The question is not whether the medication is strong enough. The question is which side of the body the treated acid is pulling against for 8 hours. Now, the gastric anatomy is only the first asymmetry that sleep position matters for, because your cardiovascular system has an equivalent problem, and the physics operates through a different vessel on the opposite side of the spine. The inferior vena cava, the large vein returning blood from the lower body to the right atrium of your heart, runs along the right side of the spine. When you lie on your right side, your body weight compresses the inferior vena cava against the spine, partially obstructing venous return. Blood returning from your legs, your kidneys, your liver. All of it passes through a vessel, being compressed by the weight of your abdominal contents, pressing it against the vertebral column. The obstruction is not complete, it is partial. A narrowing of the vessel diameter that reduces flow rate, the way stepping on a garden hose reduces water flow without stopping it entirely. When you lie on your left side, the inferior vena cava is unloaded. Gravity pulls the abdominal contents away from the vein rather than over it. Venous return improves. More blood reaches the right atrium per cardiac cycle. Your heart receives a more complete preload and pumps more efficiently against lower resistance. The difference between the two positions is the difference between a pump receiving its designed input volume and a pump operating against a partially kinked supply line. Same pump, same demand, different supply. The difference may not be conscious. You do not feel your inferior vena cava being compressed, But the cardiovascular system registers the compression through the baroreceptor reflex. When stroke volume decreases, heart rate increases to compensate. In pregnancy, where inferior vena cava compression is dramatic, the heart rate response is measured directly. In non-pregnant adults, the compression is smaller and the heart rate response has not been directly measured in sleep position studies. But the baroreceptor mechanism is identical. Your heart during right-side sleeping is likely working somewhat harder, not because of disease, not because of fitness, but because the plumbing is being compressed by the weight of the body it serves. The difference in cardiac preload between left and right lateral positions was measured most dramatically in pregnancy studies, where the enlarged uterus causes severe inferior vena cava compression, enough to cause maternal hypotension in the supine position. But the physics applies to everyone. The inferior vena cava runs along the right side of the spine in every human being. Body weight compresses it in every right lateral position. The compression is smaller in a non-pregnant adult, but it is present, it is measurable, and it operates for 8 hours every night. Consider what this means. Your heart works slightly harder when you sleep on your right side, not because the heart is different, because the vein that feeds it is being compressed by your own body weight against your spine. 8 hours of marginally reduced venous return every night across years and decades is a cumulative hemodynamic load that left-side sleeping eliminates. The heart that receives complete preload all night operates at a lower heart rate, with better stroke volume, with less energy expenditure to move an equivalent blood volume. The heart working against partial inferior vena cava compression operates at a higher rate, with reduced efficiency, consuming more oxygen to achieve equivalent cardiac output. The difference on any single night is clinically insignificant. Accumulated across years of nights, it is a workload your heart performed that it did not need to. And then there is the system most people have never heard of, the system that depends on gravity more than any other, because the lymphatic system has an asymmetry so profound that sleep position changes where 75% of your body's lymphatic drainage converges. The lymphatic system, the network of vessels that collects interstitial fluid, filters it through lymph nodes, and returns it to the bloodstream, has a structural asymmetry that is rarely discussed outside anatomy classrooms. The thoracic duct, the largest lymphatic vessel in your body, collecting lymph from the entire lower body and the upper left body, drains into the venous system at a single point, the junction of the left internal jugular vein and the left subclavian vein. 1 point. On the left side, approximately 75% of your body's lymphatic drainage converges at that point. Lymphatic vessels have thin walls and operate at low pressure. Unlike the cardiovascular system, which has the heart as a central pump generating pressure that moves blood, the lymphatic system has no central pump. It depends on external forces to move fluid. Skeletal muscle contraction compressing vessels during movement, respiratory pressure changes from breathing and gravity. During sleep, when your muscles are largely inactive and your breathing is shallow and regular, gravity becomes the primary driver of lymphatic flow. The direction of gravitational force determines whether lymph moves toward the drainage point or away from it. In left-side sleep positions, the thoracic duct drainage point sits at a lower gravitational potential than much of the lymphatic network it serves, facilitating flow from the right side of the body and the lower extremities toward the drainage point on the left. In right-side sleep positions, the drainage point is higher than much of the network, requiring lymphatic flow to move uphill against gravity through low-pressure, thin-walled vessels with no pump to drive it. Morning swelling, puffy hands, swollen ankles, a feeling of fluid retention that resolves within an hour of standing can be a sign of impaired overnight lymphatic drainage. The swelling is the interstitial fluid the lymphatic system should have collected and returned to the bloodstream during the night. In the upright position, gravity assists drainage from the extremities toward the thoracic duct. In left-side sleep, gravity-assisted drainage moves toward the duct terminus. In right-side sleep, gravity opposes it. The morning swelling that disappears as soon as you stand up is gravity correcting what sleep position prevented. The fluid is finally draining once the body is oriented in a direction the lymphatic system can work with. The role of the lymphatic system in immune surveillance, filtering pathogens through lymph nodes, presenting antigens to lymphocytes, removing cellular debris from tissues, means that overnight lymphatic drainage efficiency directly affects immune function during the period when your body performs its most intensive repair and immune maintenance. The position that optimizes drainage through 75% of the lymphatic network is left lateral. The position that impairs it is right lateral. The difference is gravitational. 9.8 meters per second, squared, acting on fluid in thin-walled tubes for 8 hours. Your immune system does not know which side you are sleeping on, but the fluid that feeds it, the lymph-carrying antigens to lymph nodes, ferrying immune cells to sites of infection, transporting debris away from healing tissue, flows faster or slower depending on whether gravity assists or resists the drainage pathway. The side you choose determines the processing capacity of the system that maintains your immune surveillance while you are unconscious. Now, in 2012, something was discovered that changed the understanding of what sleep actually does, and its efficiency depends on position. The glymphatic system, a dedicated brain waste clearance pathway, the flow of cerebrospinal fluid through perivascular channels surrounding the arteries that enter the brain, collecting metabolic waste including beta amyloid and tau protein, draining along perivenous channels, was discovered in 2012 by the Nedergaard Group at the University of Rochester. The system operates primarily during sleep, when the interstitial space in the brain expands by approximately 60%, reducing resistance to fluid flow. During waking hours, the glymphatic system operates at a fraction of its sleep capacity. Your brain waits for sleep to clear the metabolic waste that accumulated during the day, and the efficiency of that clearance depends on the angle at which the drainage pathways are oriented relative to gravity. The implications for people over 65 are direct. Beta amyloid, the protein whose accumulation is associated with Alzheimer's disease, is cleared from the brain primarily during sleep through the glymphatic pathway. The rate of that clearance is a fluid dynamics problem. Fluid moves faster through tubes when gravity assists rather than resists the direction of flow. Sleep position determines whether gravity assists or resists the drainage angle. Every night you sleep, the glymphatic system is running beta amyloid and tau clearance, eliminating the metabolic waste from 16 hours of neural activity. The angle at which that clearance occurs is determined by your sleep position and alters the throughput of the system. The connection between sleep position and amyloid clearance rate is not yet established at the level of direct clinical data in humans, but the gravitational fluid dynamics of flow through tubes at different angles is not controversial. It is plumbing. Lee and colleagues published in the Journal of Neuroscience in 2015 that glymphatic transport in rodents was more efficient in the lateral sleep position compared to supine or prone positions. The lateral position provided the fastest clearance of beta amyloid tracer from the brain interstitium. The Lee data established lateral over supine or prone. It did not differentiate left lateral from right lateral. The study measured position category, not side specificity. The anatomical argument for left lateral specifically is an inference from jugular vein asymmetry, not a measured finding. The jugular veins are not symmetrical in most people. The right internal jugular vein is typically dominant, carrying approximately 60 to 70% of cerebral venous drainage. In left side sleeping, the dominant right jugular vein is positioned uppermost, and the gravitational drainage angle would be optimized for flow toward the superior collecting vessels. The logic is anatomically sound. Direct measurement of left lateral versus right lateral clearance rates has not been performed. The research is ongoing. The direct measurement in humans of glymphatic clearance rate during sleep position has not yet been done. The rodent data are the best available. The mechanism is plausible. The rodent data support lateral over supine, and the anatomical argument for left lateral specifically is consistent with jugular asymmetry. But it remains an extrapolation, not a confirmed finding. And the heart itself has a positional preference, because it is not centered in the chest, and the way it is suspended within its membrane shifts with your orientation. The heart sits in the left hemithorax, suspended within the pericardium with its apex pointing toward the anterolateral left chest wall. When lying on the left side, the heart rests against the chest wall with gravity assisting its natural position. The apex settles toward the chest wall. The valves align with their designed geometry. The great vessels maintain their normal angles. In right lateral sleep, the heart hangs from its great vessel attachments, the aorta, pulmonary arteries, and vena cava, and swings to the right within the pericardium. This produces a slight mediastinal shift that alters the geometry of the tricuspid and mitral valves. For most healthy adults, this shift is clinically insignificant. The heart accommodates positional changes without measurable dysfunction. For adults with enlarged hearts, pericardial effusion, or existing valvular disease, conditions whose prevalence increases substantially after 65, the gravitational loading of the heart in right lateral position can produce measurable changes in cardiac output and valve competence. If you have noticed that sleeping on your right side produces palpitations, a sensation of irregular heartbeats, or nocturnal shortness of breath that does not occur on the left side, gravitational shift in cardiac geometry is a plausible explanation. The mechanism is anatomically sound. The gravitational change alters annular geometry, and the effect would be greater in hearts with age-related dilation. But direct measurement of positional valve competence during sleep has not been performed. The connection is mechanically coherent. It is not yet a confirmed clinical finding. Now, think about what it means when all of these systems converge. Every system described here, gastric reflux, inferior vena cava compression, lymphatic drainage, glymphatic waste clearance, cardiac pericardial geometry, each with its own anatomy, its own fluid dynamics, its own evidence base, all favor the left lateral sleep position through a single mechanism. Gravity acting on fluid and tissue in asymmetric structures. The convergence is not designed. It is the consequence of a body whose internal organs are arranged asymmetrically, lying horizontal in a gravitational field that does not switch off during sleep. No physician has ever asked you this. Which side do you sleep on? No health assessment includes sleep position as a variable. No prescription for reflux medication comes with a note about gravitational vectors. The side you choose every night, a decision you make unconsciously, maintain unconsciously, and were never told anything about, determines the gravitational vector applied to each of these systems for 8 hours. The reflux that wakes you, the morning swelling that disappears by midday, the cardiac efficiency during the hours your body uses for repair, the rate at which your brain clears the metabolic waste of the day. All of it is influenced by which side of the body faces the mattress. The variable has been there every night of your life. It was never measured because nobody thought to ask. No single system makes this case alone. The reflux data are the strongest. The 50% reduction in acid exposure from the Corey study is measured directly in humans with ambulatory pH monitoring. If you experience nighttime reflux, left-side sleeping has clinical-grade evidence behind it. The inferior vena cava compression is established physics, confirmed in pregnancy studies and applicable to all bodies. The magnitude in non-pregnant adults is smaller, but the mechanism is identical. The lymphatic drainage is anatomically sound. The thoracic duct terminates on the left. Gravity-assisted drainage in left lateral position. No study has measured overnight lymphatic flow rate by sleep position in humans, but the direction is right. The magnitude is unmeasured. The glymphatic data are the most preliminary. Rodent data supporting lateral over supine with anatomical reasoning, but not direct measurement supporting left, specifically over right. The cardiac geometry is mechanically plausible, but not measured during sleep. Multiple systems at multiple levels of evidence, all pointing in the same direction. The direction is left. The person sleeping on their right side tonight is not in danger. They are not making a mistake that will produce immediate consequences. They are choosing a gravitational orientation that works against these systems for 8 hours, modestly, not dramatically, but consistently, night after night. The person sleeping on their left side is choosing the orientation that works with them. The difference on any single night is marginal. The difference across years of nights consistently in one direction or the other is a cumulative variable that no longitudinal study has measured, but the physics makes directional. Now, the practical question. Knowing the physics changes nothing if the body cannot adopt the position. Habitual sleep position is one of the most deeply consolidated motor patterns in the human body. You have been sleeping in a preferred position for decades. The motor patterns that maintain that position during sleep operate below the level of consciousness. You roll, adjust, and reposition without waking, guided by a motor program your nervous system consolidated years ago. Transitioning to left-side sleeping requires working with the unconscious motor system rather than against it. Studies on sleep position reconditioning generally use physical barriers, body pillows behind the back, gentle inclines favoring the target position, structures the sleeping brain encounters and respects without waking. The barriers are not permanent. They are training aids for the unconscious motor system, providing a boundary that prevents habitual rolling to the non-target side. The first nights feel strange. Your body is accustomed to a different pressure distribution, different shoulder loading, different hip alignment. The unfamiliarity is not a signal that the position is wrong. It is the motor system encountering a configuration it has not maintained nightly across decades. For the person over 65 with left shoulder pain or left hip discomfort, common issues that make left side sleeping initially uncomfortable, a pillow between the knees reduces iliotibial band tension and aligns the pelvis. Support under the rib cage reduces shoulder compression. The skeletal discomfort is a joint loading problem, solvable with support placement rather than position abandonment. The goal is not to endure discomfort. It is to distribute the load so the skeletal system adapts to the new position as comfortably as it accommodates the one it has used for decades. Adaptation periods of 2 to 4 weeks are consistently reported. After that, the new position feels natural. The unconscious motor system incorporates it. The accessories become optional. The body has learned a new pattern. This convergence, every fluid system in the body that depends on movement through asymmetric tubes, each with independent anatomy and independent evidence, all aligning with left lateral positioning through a single gravitational mechanism, is what made sleep position irreversible for me once I saw it. Because it means the side you sleep on is not a matter of preference. It is a gravitational variable that determines the direction of gravitational force on every fluid system in your body for 1/3 of your life. Your body spends approximately 1/3 of its existence asleep. During those hours, gravity does not stop. It acts on gastric contents, on venous return, on lymphatic flow, on cerebrospinal fluid, on the heart itself, continuously for 8 hours, in whatever direction you are oriented. Sleeping on the left side aligns gravity with your body's internal asymmetries. Tonight, you will choose a side unconsciously, habitually, based on comfort rather than anatomy. But now you know what the choice determines. Left side sleeping is not a wellness trend. It is the gravitational orientation that matches the internal architecture of a body whose organs are not symmetrical and whose fluid systems depend on direction. The physics works whether you know it or not.